Welcome to the Inhale Lung CQI discussion of aerosol drug delivery. This is the first of two videos that will discuss different drug delivery devices. This video will focus on the most common delivery device for inhaled medications, the metered dose inhaler, or the MDI. Part 2 in this series will focus on other types of delivery devices, such as the dry powdered inhalers and nebulizers. To gain a foundational understanding of the factors that influence where aerosolized particles land in the respiratory tract, please refer to our video on the science of aerosol deposition. So I'd like to briefly mention that I do not have any financial relationships with any pharmaceutical companies or respiratory equipment manufacturers discussed here. Where possible, I've tried to utilize generic drug names and use non-branded visual images. Some of the slides do include references to brand name drugs or show brand names in images. This is either from the source material used or included to help clinicians connect concepts to brands they may know. Importantly, Inhale does not endorse or promote any particular drug or product. So why does knowing about aerosol drug delivery matter? Delivering medications to the lung topically through aerosol delivery can dramatically reduce side effects associated with systemic administration. It's also important because efficacy of aerosol meds depends on good delivery to airways. Knowing factors that improve drug delivery to the target tissue helps prescribers select the most effective delivery device for their patient. So where do inhaled aerosols go? While the goal is to deliver inhaled medications to the lung, in practice, only a small portion of the dose that leaves the delivery device is deposited in the lung. The remainder is wasted into the environment, is deposited into the mouth, or is swallowed. Medications that are swallowed can be distributed through the body and can have impact in the gut or the systemic circulation. Even for aerosols that do land in the respiratory tract, there is uneven deposition to the different regions of the lung. For most respiratory conditions, including asthma and COPD, the goal is to optimize delivery to the airways where the pathophysiologic changes are occurring, the bronchi and the bronchioles. There are many factors that influence how aerosols flow into the lung and where they land. First, there are the properties of the aerosol and the particle itself. The list on the left highlights several of these properties. One key factor is the average size of the particle leaving the device. This is known as the mass median aerodynamic diameter, or the MMAD. Another important feature is the speed of the aerosol as it leaves the device. This can be influenced by the particle and drug characteristics, but also by the device, the propellants, and the patient breathing characteristics. Indeed, the properties of the device and the patient can dramatically influence where the aerosols land. Several of these properties are listed on the right-hand side. These include the anatomy of the airway and differences between children and adults. Some of the variation has to do with the technique the patient uses to inhale the medication, and some has to do with limitations the patient may have interacting with the delivery device, such as inability to close lips around a mouthpiece or coordinate with an actuation. Finally, disease state, including the degree of airways obstruction and respiratory breathing pattern, can also be influential. This slide shows how particle size influences the mechanism and the location for deposition, with the smaller particles landing deeper in the lungs. There are 4 types of aerosol generating devices commonly used for asthma and COPD medications. The most common is the pressurized metered dose inhaler, or MDI. This can be used with or without a valved holding chamber. As an aside about terminology, many people use the terms spacer and valved holding chamber, or VHC, interchangeably, though these are actually separate things. Whether you call it a spacer or a chamber is less important than whether the device that you're using actually has a one-way valve to contain the medication. This figure highlights the dramatic differences in efficiency of different device types in delivering medication to the lower airways of the lung. The y-axis shows the proportion of the dose that leaves the device and reaches each location, while each bar along the x-axis represents a different delivery system. The red color represents the proportion of the dose that lands in the mouth and throat, while the blue color represents the proportion that lands in the lower airways of the lung. This is what we're trying to optimize. The first thing you notice is that all of the delivery systems are relatively inefficient, with at most only 40% of the dose reaching the lower airways. The least efficient system is shown on the far left, which is the traditional MDI, or pressurized metered dose inhaler, used without a chamber. Only about 10% of the nominal dose reaches the lung. This system also has a very high proportion of the dose that lands in the mouth and upper airway, where it's not needed. On the far right is the dry powder inhaler, or the DPI. About 18% of the actuated dose reaches the lungs, which is a significant improvement over the MDI alone lung deposition. Though DPIs also have a significant oropharyngeal deposition. The most efficient system is shown near the middle, which is the traditional pressurized metered dose inhaler used with the valved holding chamber with a non-electrostatic internal coating. Of course, individual patients may have widely varying drug delivery depending on their willingness to use the device and their specific inhalation technique. Now, a few slides back, we talked about the importance of aerosol size in determining where a medication will land within the respiratory tract, with the target particle size being less than 5 microns. In general, metered dose inhalers and dry powdered inhalers generate relatively uniform particle size. This is in contrast to nebulizers, which create heterogeneous populations of particle sizes. Now, this slide is a few years old, but it shows that in general, the MDIs and DPIs are generating particles with the goal diameter of less than 5 microns, but there's important variation by drug and device. The figure shows that in general, the smallest particles, those that are close to 1 micron in size, shown at the bottom, are more likely to reach the desired location and have greater lung deposition, up to 50%. Switching to a smaller particle-sized device can potentially improve asthma or COPD control. The most common aerosol delivery device is the traditional pressurized metered dose inhaler, known commonly as the MDI, or more technically as a PMDI. Correct PMDI technique first involves firing the MDI while breathing in deeply and slowly, and following the inhalation with a breath-holding pause to allow the particles to sediment on the airway surfaces. Most instructions recommend placing the mouthpiece between closed lips, but it's also possible to hold the inhaler between open lips or even a few centimeters from the mouth. Misuse of PMDIs is common among patients, and poor understanding of how to use a PMDI also appears to be widespread amongst health professionals. Most importantly, the PMDI must not be fired after the patient has completed an inhalation, as then there will be no airstream to carry the aerosol into the lungs. Some of the aerosol will probably still reach the lungs if the PMDI is fired shortly before inhalation begins, but failure to correctly time firing with inhalation, sometimes called poor coordination, is an important reason for decreased drug delivery. As we saw in the earlier figure, when pressurized MDIs are used without a valved holding chamber, typically only about 10% of the actuated dose is delivered to the lungs. Valved holding chambers, or VHCs, enhance the performance of PMDIs in several important ways. First, they reduce the need to coordinate the actuation of the MDI with the inhalation. Second, they reduce the oropharyngeal deposition of the drug, which in turn reduces the likelihood of local side effects. Third, for drugs with significant GI absorption, a VHC reduces systemic absorption and systemic side effects. And finally, the valved holding chamber maximizes pulmonary deposition of an aerosol by reducing the velocity and size of the aerosol particles and retains the non-breathable particles greater than 10 microns in the device. They reduce the throat dose and improve pulmonary deposition by allowing the jet from the actuator orifice to decelerate. The one-way valve in the chamber keeps the aerosol contained, allowing time and distance for evaporation of propellant that promotes the formation of the small particles. A common misconception is that valved holding chambers are only for younger children, but because they improve lung deposition and reduce oropharyngeal deposition so much, they improve effectiveness and reduce side effects for all age groups. To reiterate, the MDI requires a high degree of coordination and psychomotor skill, with inhalation, actuation, and breath holding all occurring in a precise sequence. In practice, few adults and even fewer children can use a pressurized MDI correctly, and less than 15% of the emitted drug enters the typical patient's lungs. For the VHC to effectively assist with medication delivery, it's important that the patient generate a tight seal around the mouthpiece with their lips, or alternatively, that a mask is used that can generate a tight seal with the face. The figure on the left shows the difference in drug delivery in children when there's an effective seal with a mask. In the far left image, there is a poor seal, and most of the medication is lost and not delivered to the lungs, while in the center figure, when a mask is used with an effective seal, delivery of the medication to the lungs is significantly enhanced. Of note, masks for spacers usually come in infant, pediatric, and adult sizes, as shown in the series of pictures on the right. Infants, younger children, and anyone with significant cognitive or physical disability will require assistance from a caregiver, though older children and most adults will be able to self-administer. So there are two inhalation techniques that are commonly used for taking medications with a pressurized metered dose inhaler and valved holding chamber. The preferred technique starts with maximal exhalation to empty the lungs of air, followed by a slow, deep inhalation and a 6 to 10 second breath hold. This is an ideal choice for patients who have the ability to take a deep breath and hold it. It's also good for patients with usual cognitive ability who can follow instructions. An alternative technique is the tidal breathing technique, which is typically used with the valve holding chamber in conjunction with a mask. This is a good choice for those who are unable to take a deep breath and hold it, for those who cannot make a tight seal on the mouthpiece with their lips, and for those who cannot follow instructions. With this technique, the face mask is applied to the face, an assistant will actuate the device, and the patient just takes 6 to 10 regular tidal breaths. In summary, pressurized metered dose inhalers are small, convenient, and readily available. However, by themselves, they're very inefficient at delivering medication to the lung and have large oropharyngeal deposition. Medication delivery from PMDIs can be significantly improved by using them with a valved holding chamber, also called a VHC or a valved spacer. VHCs are recommended for use with both children and adults, and patients who are unable to make a tight lip seal or to take a deep breath will benefit from using an MDI chamber with mask combination using the tidal breathing technique. Thank you, everybody, for watching.